Nice to be with many of you. I've known for a long time. Jimmy, Chris, always good to be on a panel with you. I'd actually like to begin, and I'll pick up on some of the themes that excellent points have already been raised. I do think it's important when we talk about global health to put it in the context of the world. It doesn't exist separately, and the world is a very changing place. There's so much in flux right now, politically, socioeconomically, power paradigms, and really ideas and people are moving and on the move in ways that we have rarely seen in the world. And some of that is related to demographics. And all of you are very, very conscious of the growing of the population of the world, and particularly sub-Saharan Africa, where we're projecting, or the World Bank is projecting, a doubling of the population by 2050. So I really think global health has to fit in the context of the world and where the world is, and the future of global health and the future of U.S. engagement, therefore, fits into that very complex picture. Certainly within that picture, there are enormous challenges, but wherever there are challenges, there are opportunities. You know, if we look at the Millennium Development Goals and the Sustainable Development Goals, the biggest shift to me, and, you know, we can debate whether or not there are too many specific targets, and, you know, Chris and I probably have some views on that. But the overarching theme of moving from focusing from an issue or a specific area to try to focusing on a person and therefore a community, country, and global issues, I think is a hugely important step. And that is, I think, at the essence of what some of the questions you've raised with us, and how you get to a multi-sectoral approach, because if you're focused on a person, you really have to do that. And we've had enough time getting the global health world to work together, let alone trying to cross sectors. So how could we start to do that? And there are two basic ways to do it. One is political and architectural, and there's been huge volumes of stuff. I have to say, back when I was an academic, I contributed to some of that, about how we could restructure the global, at least, health architecture. You know, the practical side of me is by the time we get around to doing any of that, it'll lead to a lot of nice meetings, a lot of nice meals. But by the time we ever actually did any of that, which I doubt we would ever do because it's too difficult politically, the world will have moved on. We'll be talking about something that's not particularly relevant because it's just too complicated. So then it gets to behaviorally, can we actually start to focus on a person and a multi-sectoral approach? And the only way to do that is to get specific. We can have general conversations, we can talk for a long time about this, but if we start to focus on individual people in individual places, and you can have an entry point of that from a health perspective, I think we can start getting somewhere. And Chris raised something which is hugely important, which I think relates a lot to the big changes in the world, which is adolescent girls and young women. By the way, I would add before going into specific that, you know, people are very worried about refugees today and migratory patterns, which I completely understand. I mean, I think a point we need to continue to make is, again, looking at the demographics, and this is why I raise adolescent girls and young women. You know, the reality is, if we don't, and this is why Chancellor Merkel is focusing the G20 on it, if there isn't development, if there isn't education, health, economic growth in Africa, in parts of the world that still don't have such things, you know, what we see today as refugee crises are a drop in the bucket, because there will just be no place for people to go except away from home. And we really have to start focusing on these issues. But again, I think it's a complicated thing, and everyone wants to put their finger on their one issue, which gets back to the SDGs, and how do we actually begin to change the way we not only think, but how we act, but first to change the way we think. So I think adolescent girls and young women related to HIV are an entry point and a window into how that could be, with broad implications for development more broadly, and broad implications for how we could actually see a change in the world that could be meaningful in development, driven through gender equality and gender empowerment. So as Chris mentioned, and Jimmy, you know, there's been enormous success in HIV I really want to congratulate the broad PEPFAR team, and HHS, CDC certainly contributed a great deal to the impressive data that was put out on World AIDS Day, which really helps us get to understand things in a more complex way. And one of our problems for the last 15 years, and certainly I've been a part of it for the early stages, is kind of the tyranny of averages. We look at things broadly. We look at national averages or global averages, when the reality is there is no such thing as a global HIV epidemic, a global TB malaria epidemic, or a global NCD epidemic. And particularly with some of the infectious diseases, they aren't even national or regional within a country. They're very focal. They're very isolated. They're microepidemics. And while we're beginning to understand who we're missing, we're getting very good coverage rates of antiretroviral therapy, for example. In 3 countries, suppression of viral load is about 90% in the community, not even in the clinical setting. But if you look at the data, the young people, 25 years and younger, are being missed. They're not part of that solution. In particular, girls, and in fact, in some of the countries, the risk to an adolescent girl, as Chris kind of alluded to, is 14 times higher than to an adolescent boy or young man. It was not until you got to 25 or older, and we're actually, from the data which Chris talked about, including phylogenetic data, understanding that it's 25 to 35-year-old older men that are having sex with younger adolescent girls and young women, and leading to a very high rate there. Then as you get older, those women are having sex with the older men, you're equalizing the pool, and then you start that cycle all over again. But what we're not understanding, so we're understanding the who we're missing, those 25 to 35-year-old boys, young men that we're not accessing, and the adolescent girls and young women who we're not accessing. What we're not getting to is why. And, you know, at the beginning of the HIV response, we were heavily focused on anthropology, behavioral, cultural issues. We've kind of lost that over the last 15 years, and we're very focused on medicalized issues, which I completely agree with. I mean, I come from that background, and certainly was very involved in programs that led to a high medicalization, and we need that. We absolutely need it. But if we're going to actually get to the end of epidemics, we're going to have to actually understand who's at risk of disease and why. And this is not unique to HIV. It's just an entry point. You can do it for TB, malaria. You can do it for NCDs. You can do it for almost anything. And as we look at the data, although it's pretty limited, and we need to do a lot more intensively on the anthropology, the behaviorists, the cultural pieces, what we're starting to understand more is something we understood at the beginning, is it's very cross-sectoral. That girls out of school are boys out of school for that matter, are much more at risk. But why are they out of school? Well, it can be pretty complicated things, like not feeling safe walking to school, like maybe not feeling safe being in school when they're in their menstrual period. There are very complicated social issues. There's gender-based violence that feeds into this, which is a very cultural thing. And so we need to actually look across sectors. So one of the things that we're doing, which I'm most excited about, is trying to understand who's at risk, why they're at risk, from broader than a medical perspective, so that we can understand the package of interventions across sector that will have an impact. And what we're really looking at then is engaging not just ministries of health, but actually engaging heads of state, ministers of education, ministers of finance, ministers of social development, where they exist, ministries of gender and sport. And we're doing this collectively with PEPFAR and the DREAMS program, with the Global Partnership for Education, with Girls Not Brides, because in a lot of these areas, girls are getting married at very young age, which makes them highly vulnerable. And actually with Gavi too, because we have access, for example, PEPFAR and the Global Fund, to adolescent girls and young women in a variety of ways, but so does the Global Partnership for Education and Education Ministries, or girls out of school or young boys out of school. Gavi has access to young girls through the HPV vaccine. If you're providing an HPV vaccine, you ought to be making sure that there's a full package provided. In the same way, if we're reaching adolescent girls and young women, we need to be driving them to the HPV vaccine. So we're actually working intensively, and so far actually South Africa and Swaziland are really picking this up and trying to do national scale, cross-sectoral programs. But what we're trying to do is bring the sectors together and bring the organizations together to support countries to say, if we need an adolescent girl and young woman to become, which means beginning even younger, to become a young woman of opportunity, what does that mean? And where do we need to intervene? And that includes, how do we deal with boys? Because boys that become 25-year-old men are the ones that are preying on and abusing young girls and adolescent girls and young women. And how then do you design and follow programs that are for that purpose? Now, we can engage in this because the data are telling us that girls that stay in school might have a lower risk of HIV. And we've known this for a while. But we're starting to understand some of the ways to try to keep girls in school, to get them out of vulnerability. There's increasing data on how you engage in gender-based violence. But without the data, we actually can't really engage. But you have to do it community by community because, as I mentioned, these are all micro issues and micro epidemics. And you need to really understand community by community why people are at risk, who they are, so that we can focus on them and focus on the package of services that could make a difference, implement them, track them, and modify them over time, working closely with the communities. And it has to be across those sectors because these issues are not, at this point, HIV is as much a societal disease and gender equality disease as it is a medical disease. And I would point out that while HIV is our entry point, if a girl stays in school, she's much less likely to be a child bride. She's much less likely to get pregnant early. She's much more likely to have fewer children, and she's much more likely to have an income. And if she has an income, we know that a mother will spend about 80% of it to feed, educate, and provide health services to her child, whereas a man will spend maybe a third of it, maybe 40%. So you start to have a big cultural change when you engage in these issues across sectors. And here I'll come back to the demographics and this huge growth in the young population, which can be pretty frightening, especially if you're looking at HIV and other communicable diseases. But it can also be an opportunity because if we get this generation right, not in the not too distant future, this generation will comprise 60, 70% of population. And while it takes 3 to 4 generations, sometimes 5 to 6, and we're all still struggling with gender empowerment and equality, if you have that big of a change in that so dramatically short period of time, there's actually hope that you could change significant cultural practices and norms within a generation. So it's a huge opportunity if we take advantage of it and engage, but it can only be done in a cross-sector way. 2 other issues you asked that I'll just touch on, which is results-based financing and the pros and cons. I'll say the pro is the only way to raise money in the current environment is to have results-based financing. There is no other way. If you don't show results, you will not get money. But you can focus your results, what kind of results you're after are important. So if your only result is what's your HIV rate, it's a little more complicated. If your result is what's your HIV rate in adolescent girls and young women, you then start having a broader view. So designing indicators, if you also want to look at what's the age of pregnancy, what's first pregnancy, how many children you have, do you have an income? These things all start to fit together. So these are not squishy things. They're actually results. And you can do results-based financing that actually drives towards multi-sectoral work, depending on the result you're trying to get to. And they're actually not that complicated. Some of them are, but some of them aren't that particularly complicated. And so we can start where we can start if we get specific. The other issue related to non-communicable diseases, which has been touched on, and the issue around systems. And I agree that health systems seems confusing, but it's actually not if you break it down into component pieces. Just like if you break down HIV infection to its component pieces, you start to get refined. So the more you break things down and use data, the more you can actually do well with systems. So massive work has been done that shows the procurement and supply chain are 2 huge lesions to getting to the end of the HIV, TB, and malaria epidemics. They're also massive lesions to providing good non-communicable disease or to respond to an emergent threat or to manage antimicrobial resistance for that matter. So focusing on key pieces of systems like procurement and supply chain, quality, the quality of programs, and understanding site by site, provider by provider. And there are good examples of this down to the community level. Use data, but use data that's appropriate for each level. So what data system does a community healthcare worker need to respond to a fever and to try to figure out if it's Ebola or a malaria or something else for a child, and actually know how to report that? And Ethiopia actually has done a great job. So you can have quality systems with the right system of data and the well-trained people at each site of the system. And if you do these systems pieces that have clear, definable approaches, you can actually invest in systems which can then be used for non-communicable disease. And this is what we're trying to do at the Global Fund, and we're working very closely with both the Gates Foundation and PEPFAR on that. So it's a delight to be with Chris and with Jimmy and with all of you. And with that, I will just stop by saying there's huge flux, there's huge change, but there's huge opportunity. And we have to think and act differently, but we can only do that if we focus on specific things, get real, get data, get results. And if we do all that, I'm very optimistic.